cells, which was also honored by a Nobel Prize. So I was working on interaction between retroviruses, mostly animal retroviruses, and the host, to see what role these retroviruses could play in leukemia and cancer, when we got this first alarming sign of an emerging epidemic published in MMWR, the CDC journal, in June 1981, reporting the first cases of pneumocystis carinii associated with profound immune depression in very young homosexual patients in the United States. Soon after, the first cases were recognized in other patients. Hemophiliac, also women presenting with the same symptoms, and as well as first cases of infected children born from infected mothers. If I mention that, it's because as soon as 1982, we had already the knowledge of the mode of transmission of the etiological agents. We knew that the etiological agent could be transmitted by sexual route, by blood, and from mother to child. And this is really, if I'm showing you this slide, is to keep you in mind, especially the future scientists in the room, that scientists alone should be careful about the observation of clinicians and epidemiologists as well. Because for our case, working in biomedical science, it's really the clinicians that came to us at the Pasteur Institute, because they were starting to see the first case of this disease that later was called AIDS. And they asked us a very simple question. You, as a retrovirologist, do you think that a retrovirus could be the cause of this new emerging disease? Of course, if they came to us, it's because soon before, in 1981, the first human retrovirus was identified in the United States and very soon after in Japan. We knew it as human T leukemia virus. And the clinician knew that this human retrovirus was capable to infect T cells. And they said, look, in our patients, they are losing all their T cells. We say, yes, okay, but HTLV, it's a retrovirus that immortalizes the cells. The cells are proliferating, they don't die. However, we had in mind that another retrovirus in animal, feline leukemia virus, was capable to cause in cats immune deficiency, and very often the cats were dying of immune deficiency before dying of leukemia. So we told our colleagues, the clinicians that are on this slide, look, we have today the new technology, and we have the technology in the lab, especially since it was reported, the identification of growth factor, at that time called T-cell growth factor, now known under the name of interleukin-2. So we had the possibility to grow T-cell into culture. Now we have to decide the approach that we are going to use. The reason why on that slide I say, when you start a research program, don't keep in mind dogma. Because if we had started with the idea that HTLV could be the cause of this emerging disease, indeed, we certainly did not have done what we did. we would have wait for weeks into culture to see the expansion of transformed cells. We said, no, we're not going to do that. We're going to look every 2 or 3 days maximum to see whether we are capable to detect any viral activity in the supernatants of the cells, reverse transcriptase activity, namely. The second important decision that we took together with our colleagues at clinicians, we said, look, you want us to try to identify a virus from CD4 lymphocyte in patients that do not have any more CD4 lymphocytes in their blood. This is certainly not the best moment. So our colleague, Willy Rosenbaum, on this slide said, okay, but before they are developing generalized lymphadenopathy, and we asked, can we have a biopsy, a lymph node biopsy from a patient? And the 3 partners in this story appear, the patients. The patient, because very kindly, one patient accepted only for research purpose to have a lymph node biopsy. So it's how the story began, and it's how it's really a very nice cooperation that was successful between clinicians, health workers, patients, all together. It's how we report in the May 1983, for the first time, the identification of a virus that at that time we call lymphadenopathy-associated virus, because it was isolated from a patient with lymphadenopathy. We did not call it at that time yet HIV. We report in that paper that the virus could be propagated on peripheral mononuclear cells of blood donors or on cord blood cells. We report that we were able to detect a reverse transcriptase activity which was associated to virus particle of the same size and same, let's say, morphology of retroviruses, but according to HTLV1 condition. However, the morphology of the particle was not already the one of HTLV1. Indeed, we in contact with our colleague Bob Gallo in the United States, we asked whether we could have reagents, HTLV1 reagents. And in that paper, we were able to show that one of the proteins of our virus, LAV, was not cross-reacting at all with the equivalent protein of HTLV1, the P24. It was the same for another protein of HTLV1. We were reporting also in that first paper that a second patient was presenting antibody against our virus, and the other donors or other patients with other disease were not reacting against our virus. So that was really the beginning of a long story. We certainly did not at that time, in 1983, at the reality of the magnitude of the epidemic that we have today. We realized only later on that we had to face a terrible epidemic affecting the whole world. After this report, we had to convince the scientific community and the authorities that this virus, LAV, was the cause of AIDS. That means that in our lab, we had to stop any other research program that was going on. We had also to mobilize other cooperation, multidisciplinary cooperation. That was a key issue and is still a key issue for the future. We had to mobilize other like immunologists, molecular biologists, and so on, to come and work with us, to make the link between this virus and the disease itself, to show that we were able to isolate the virus only from patients with AIDS or AIDS-related symptoms, but not from any other disease. Together with clinical virologists Christine Ouziou and Francoise Barre-Sinoussi, we set up very rapidly ELISA test for making seroepidemiological investigation to show that only patients with the disease were presenting antibody against our virus and not the others. We had to characterize the virus itself as genetic level, antigenic level, and so on. So, as you can imagine, it was quite a lot of work to do, but we knew already that we had to rush. We had to rush because we knew that the virus was transmitted by blood. We knew that we had to develop very rapidly, as it was mentioned before, serological tests for the diagnosis and to avoid at least transmission by blood. That means that we had to mobilize also the private sector. Cooperation again between the public and the private sector, and we had a very strong and efficient partnership with the company Sanofi Diagnosis Pasteur. So if I mention very rapidly these stories, because HIV research is really an example of a wonderful collaboration at multidisciplinary level, and it's an example of translational research, very rapidly translational research. After the identification of the virus, we made the diagnostic test to prevent the transmission by blood, as I mentioned. But even by making study on the tropism of the virus for CD4 cells, and also to study the cytopathic effect of the virus on these cells, we brought the evidence that monitoring CD4 cells in patients was the right way to go. We characterized the HIV-1 replication cycle very rapidly with Dominique Dormois and other colleagues working with us, and the reverse transcriptase of this virus, and we started as soon as 1984 to test for antiretroviral drug on the purified reverse transcriptase activity of this virus. It turned out that the first drug we tried was not a good one. But not so far after, in 1985, 1986, colleagues in United States showed that AZT was a very active anti-reverse transcriptase drug and was very fast tested in human as the first antiretroviral drug, and it was the first antiretroviral drug showing a prevention of mother-to-child transmission. Sorry. So, during the last 27 years, I'm showing this slide to indicate only very important, the main milestone that has been made all over the year. It was mentioned before, we characterized very rapidly the genome of HIV-1, and as soon as at the end of 84, we knew already by comparing the virus from one patient to the virus of another patient that they were not the same. So we very rapidly learned that we had to face a very diverse virus. And over the year, we have learned about the diversity of HIV-1 at the Pasteur Institute. We also isolate the second type of virus, HIV-2. And you know that today, we know that both virus HIV-1 and HIV-2 result from introduction into human of monkey viruses, chimpanzee for HIV-1, Sooty Mangabe for HIV-2. So we have learned a lot about HIV biology, HIV pathogenesis all over the year. I am not going to enter into detail. If I'm showing you this slide, it's just to indicate